just remind you, we are not going to have Dr. Anderson this Friday. It's going to be on the next Friday, on the 8th of October. Now we are having every other Friday, the morphology series of Dr. Anderson. So please join us on next Friday on the 8th of October. I'm sure it's going to be amazing. And please take a look on our YouTube channel. We have very interesting things there, including a series of the history of pediatric cardiology. Every week we are launching a new episode. It's going to be in total 10 episodes talking about the history of each of the cardiac disease. So this is a very interesting series done by our colleagues from Sick Kids. So now with you, I'd like to invite Dr. Rima to introduce the series, introduce our speakers from a very nice group of speakers from the US today. I'm sure everybody is going to enjoy. Thank you, guys.
Thank you, Grace. I'm so grateful for Grace and Sasha, the co-founders of Congenital Heart Academy, and me, Rima Bader, the course organizer and professor of pediatric and fetal cardiology. Now, this is our 9th series, and really we have a lot of feedback asking for the basics of fetal cardiology. So based on that, we are trying as much as possible to address that. We have 3 eminent speakers today, and one of them, I mean, I think 2 of them are very well known to most of us in the field of fetal cardiology. We have Dr. Ernie Alboliras. Forgive me, please. And Ernie has been in the field for a long time, associate professor of pediatrics at the University of Illinois College of Medicine. And of course, he's a fetal pediatric cardiologist. We all remember Ernie because he's like the founder, one of the founders of the Phoenix Symposium, a great teacher. Ernie, you're most welcome. Thank you so much for accepting the invitation of Congenital Heart Academy. Please proceed.
Thank you very much, Rima, for inviting me to participate in the symposium sponsored by the Congenital Heart Academy. As you requested, I am presenting a talk on determination of situs in the fetus. I have nothing to disclose in this talk of mine. Fetal and transthoracic echocardiography have essentially the same
I cannot
goal.
see your slides. I don't know if it's only me.
Oh.
Ernie, you have
Rima,
to share screen. Yes.
Yeah.
Oh, sorry.
Share your screen, please, first.
But you can hear me?
Yes, we can hear you.
Yes, we hear very well.
Ernie, at the bottom,
Yeah.
you'll find something that says share screen. Yes, exactly. Yeah. Thank you so much.
So you can see the slide now?
Yes, and we can hear you.
As I said, thank you very much, Rima, for inviting me to deliver this talk, which you suggested, which is good for those who are trying to learn fetal imaging, both physician and sonographers. I'm delivering this talk, Situs in the fetus. I have nothing to disclose. Well, fetal and transthoracic echocardiogram have essentially the same goal: to provide the most accurate morphologic and physiologic diagnosis of abnormalities of the heart and great vessels. But there are factors that could affect accuracy of fetal diagnosis. There are non-cardiac factors, such as the distance of the heart from the transducer. It could be polyhydramnios, oligohydramnios, thick skeleton, age of gestation, maternal obesity. There's also the ever-changing fetal position during study. Of course, the fetus is a small size, and more so the fetal heart, particularly if you are dealing with multiple gestation. There's the accuracy in right-left orientation and interpretation, which we are going to discuss in detail. The lungs and the liver are underdeveloped. The liver is large. There's the uniqueness of the fetal circulation. especially the physiology, the size of the PDA, the PFO, the ductus venosus, and the presence of umbilical vessels. I usually follow a sequence of imaging in doing fetal echo. First is by identifying the specific laterality of the abdominal and thoracic organs through distinguishing the right from the left side of the fetus, and then determine the thoracoabdominal situs, followed by determination of the cardiac position in the chest. And only then could there be a segmental analysis performed without worry about the laterality of the heart being interrogated. And in terms of cardiac segments, we make sure that all of this are analyzed, starting from the atria, the atrioventricular valves, the ventricles. This could be two or single, the conus or the muscle separating the ventricles from the great artery, and of course the great artery themselves, in terms of connection or alignment, size, and flow direction. But first, let us sure that we know the right side from the left side of the fetus. It can be very confusing because fetuses can change presentation or can turn around within its own axis. Thus, the precise location of the heart in the chest and the various organs of the abdomen. The technique should not be dependent on maternal or uterine position, but solely on the fetal body that is being examined. I have been following over the past 26, 27 years the technique proposed by Tim Cordis and his group when he was a fellow at Mayo Clinic. And this was published in 1994, Journal of American Society of Echocardiography. It is a very simple technique, easy to learn and quick to perform. It is very accurate. It has been adopted by many fetal cardiologists worldwide. The accuracy of technique has been published in several articles by Cordis et al. Themselves, wherein they had a 100% correct orientation in 55 fetuses. Dr. Lindsay Allen said that this was reliable. And then the group from Turkey, Dr. Askutlu et al., diagnosed correctly the visceral atrial situs and the cardiac apex orientation of all of their 20 malpositions and all 124 cases of CHD with levocardia and situs solitus. The technique is simple. Just set the echo video screen in the non-inverted orientation with the ultrasound company logo to the right of the observer. Obtain a sagittal view of the fetal body, whatever its position. Orient the transducer so that the fetal head is on the right side of the observer on the video screen. Quickly rotate the transducer 90 degrees clockwise to obtain a transverse view of the fetal body for right-left orientation. Obtain then a transverse view from fetal chest to the fetal abdomen for cardiac and stomach location, and only then can detailed anatomic analysis of the fetal cardiac be performed without worry about the right and left side. This technique can be done, be it the spine being at the back or the distal part, or if the spine is in front of us. This has been shown also from the book of Chiappa et al. With Norman Silverman, wherein with the fetus in a sagittal position, rotate the transducer 90 degrees clockwise, and you get the transverse section of the chest and the abdomen. Here's an example of the rotation. You can see that the spine's down, so this is left and that's right, and this is levocardia. A detailed transverse sweep shows the stomach here on the left side, and the 4 chambers of the heart also on the left side, with apex pointed towards the left. So this can be true regardless of the position of the baby, be it the spine be on the right side, in front of us, on the left side, or at the back of the baby. Here's an example of a spine at the back, and you have the 4 chambers with the apex pointed to the left and the stomach bubble at the left side likewise. Even at 5 o'clock, 4 o'clock position, you can do that. Heart and stomach on the left side. This one, the spine is to the right, but look at where the heart is. And this was a correct rotation. You could see that the heart is on the right side of the baby. So this is dextrocardia. If the spine is above, you could see that the left side is now over here. And the right side is over here where the pointer is at. So the heart is left-sided with apex down, and stomach is seen here in the left too. We have also this demonstration showing that the spine being in the left side, but here the heart is left-sided also, apex down, and this is a patient with unbalanced RV dominant AV canal. You could also see that in this picture or movie on the right side, where the heart has been shifted to the right, and there is a mass, which is actually a diaphragmatic hernia occupying the left side of the thoracic cavity. Well, we now discuss situs. Situs is the spatial relation of an asymmetrically arranged organ system or group of related organs. The usual arrangements or normal arrangement is situs solitus, and noting the following: that the liver is on the right side, the pancreas and the spleen on the left side, the stomach on the left, and the heart on the left. That there are paired organs, the lungs and the bronchi, but only a few of them could be useful for us in fetal echocardiography, particularly since the lungs and the bronchi are certainly not imageable in their details by echo. The liver sometimes is huge, and the right-sidedness may be difficult. The pancreas and the spleen may be difficult to distinguish from each other. They're on the left posterior aspect. And the stomach is left-sided. The stomach is the one that's easiest to identify. And of course, the heart is likewise very easy to identify. These are the two unpaired organs that can give us a clue as to the situs of the fetus. The thoracoabdominal situs is important because the abdomen wherein the stomach is shown readily on ultrasound can tell us what the situs is. The stomach is the most consistently and easily seen on fetal echo. And so situs, visceral situs solitus is stomach to the left. But the one involving the tracheobronchial tree will not be, cannot be availed of on fetal echocardiography. If the stomach is on the right, that's situs inversus of the abdomen. And of course, there is the situs ambiguous, wherein we do not have an easy definition as to where the abdominal organs are. The importance of determining abdominal situs and cardiac positions include the fact that there is increased frequency of cardiac defects in malpositions of the heart and other major organs. An abnormal heart position may indicate increased complexity of associated intracardiac abnormality. The accurate determination of situs can impact the result of a planned surgical procedure. So we then go to cardiac positions. The first is levocardia, wherein the fetal heart is mainly at the left side of the chest with apex pointed to the left, or the cardiac axis is leftwards. If this is present, it's assumed to be thoracoabdominal situs solitus if abdominal organs are at usual location. Then there's dextrocardia, wherein the fetal heart is mainly at the right side of the chest. Many cardiologists term dextroposition as a type of dextrocardia wherein the apex is pointed to the left. And this can usually also be called secondary dextrocardia, usually secondary to factors that push the heart to the right side, such as CCAM or diaphragmatic hernia. Then there's dextroversion, where the apex is pointed to the right. Some people may call this primary dextrocardia. Note that the nomenclature does not involve the individual cardiac parts, including ventricles and the great arteries, because we are just dealing with the cardiac mass and its apex. Mesocardia is when the fetal heart is mainly at the center with apex pointed to the midline. And ectopia cordis is when the fetal heart is either partially or completely outside the chest cavity, so the situs is difficult to ascertain. So therefore, cardiac position is not a predictor of atrial situs. With atrial situs, we have discussions from various textbooks to distinguish the right atrium or morphologic right atrium from morphologic left atrium. If the morphologic RA is on the right side, that's situs solitus. If it's on the left side, it's situs inversus. But then you could also have an indeterminate situs of the atria. But atrial situs, it's good to know that it also defines the visceral situs. So if the stomach is on the left side, we assume that the right atrium is also left-sided, or I'm sorry, right-sided. So that's situs solitus of the atria and viscera. The right atrium and left atrium are identified by their morphologic characteristics, as I mentioned earlier, but it's difficult in the fetus. Here are the components of the atria, and the ones that are easily identifiable are the atrial appendages and the inferior vena cava. Here's an example of the left atrial appendage, which is elongated, and the right atrial appendage, which is triangular or trapezoid. The inferior vena cava may be discontinuous, but the discontinuity is almost always pre-hepatic or post-renal with azygous continuation. And Stalvan Prague has said that the inferior vena cava between the liver and the right atrium is almost always there. Septum primum, or the flap valve foramen ovale, may be large and redundant. It may be flapping to the right atrium or left atrium, so this is very difficult to use as a guide for determining situs. And coronary sinus may be difficult to determine. It could be absent. Superior vena cava could be bilateral or absent on the right. Then pulmonary veins, there could be a total anomalous pulmonary venous connections. So in this, echocardiographically, the atrial appendages and the inferior vena cava may be the consistent factor for identifying atrial situs. Now, as far as cardiac positions are concerned, levocardia, as I said earlier, is when the heart is mainly on the left chest, and the four chambers have an axis pointed towards the left. This is a patient with the stomach on the left and four chambers of the heart on the left. So this is situs solitus of the atria and viscera and levocardia. But then we have here patients on the right, over here, being the stomach. So what I usually do is I put a line from the spine all the way to the most anterior aspect of the chest. So this is now on the left side, this is the right side. So this is a situs inversus, but there's levocardia. So we can call this isolated levocardia, which can be associated with intracardiac abnormalities. Now we go back to dextrocardia. In primary dextrocardia, we have the heart on the right side with apex pointed to the right. It could be seen in the heart that's four-chambered with no abnormality. But it could also be seen in patients with cardiac abnormality, like this patient with complete AV canal. Now, in this particular patient, you have also to put a line here, and you have the right side here where the heart is, and note that the stomach is on the left. So there is situs solidus, but there's dextrocardia. Situs solidus of the viscera. Now, secondary dextrocardia is when the heart is on the right side, but a cardiac axis pointed to the left. And on the left side, we have a mass, as you could see here, which is actually several cysts from CCAM occupying the left hemithorax. Mesocardia is when the heart is pointed downwards and inferiorly, anteriorly. The heart may have a box-shaped apex. The cardiac axis is 0. And this may be seen with normal hearts, but oftentimes with cardiac anomaly, like this patient has a ventricular septal defect. And of course, there's ectopia cordis, wherein it's very difficult to determine whether it is situs solidus or situs inversus, but it is its own family, almost always associated with conotracheal anomaly, such as the double outlet right ventricle and tetralogy of Fallot. Now, when it comes to ambiguity of the atrial situs, the naming of atrial situs, you can call this heterotaxis syndrome. It's used to describe groups of anomalous visceral situs and complex cardiovascular malformations. There's often a loss of typical left-right organ asymmetry in the abdomen, lungs, and heart. There could be situs ambiguous, which could be either polysplenia, sometimes called bilateral left-sidedness or left isomerism, or asplenia with bilateral right-sidedness or right isomerism. This is not a heterotaxis symposium, So needless to say, it's important to note that fetal abnormalities can be seen associated with situs abnormality or ambiguity, such as bilateral SVC, interrupted IVC, total veins, dextrocardia, mesocardia, isolated levocardia, AV canal, RV origin of the aorta, spongiform myocardium, single ventricle, hypoplasia atresia, one ventricle, pulmonary atresia, and complete heart block. Here's an example of a patient with interrupted inferior vena cava with azygous continuation. Note that in the abdomen you see two circles. One is the aorta, and the other one is azygous continuation of the interruption of the IVC cranial to the kidney. And you could see also on sagittal view the two vessels, the azygous vein and the aorta, and further cranial analysis shows that the azygous veins connect with the right superior vena cava. We can also see bilateral superior vena cava in situs ambiguous, like these two circles. And we can evaluate the left superior vena cava. This one actually connects posteriorly to the left atrium, which is where the coronary sinus insertion is at. Then spongiform myocardium is very common. It can be seen in a normal heart, but it is also seen in complex anomalies such as this one with complete AV canal and complete heart block. Now, total anomalous pulmonary venous connections could be determined also associated with heterotaxis. This one, there's a confluence that connects to the right superior vena cava here, while on this picture or movie on the right side, we have posterior to the atria, a vessel that goes towards the liver. This is the infradiaphragmatic total anomalous pulmonary venous connection, while the one on the left is total veins to the right superior vena cava. In summary, a constellation of congenital abnormalities may exist in the human heart. The confusion in understanding cardiac imaging is decreased by having a standard way of identifying the right from the left side of the fetus. That should be independent of the uterine or maternal situation. Correct laterality of the heart and abdominal viscera are then identified, naming the visceratrial situs and the position of the cardiac mass. Only then is imaging of the cardiac segments be performed, and safely with confidence that you won't be lost as far as the right and left sides are concerned. Thank you very much.
Thank you, Ernie. Beautiful talk. The panel, the floor is open for any questions from the panel first. We're joined by Dr. Shawi from Germany, and we're also joined by Dr. Anna Colley. Now, if you'd allow me to ask you until we get more questions, Ernie, why do we have to determine the situs by any means? Why?
Mainly because situs abnormality may be associated with congenital cardiac defect. And especially if the situs is undetermined or in situs ambiguous, and even in situs inversus. I'm talking about atrial situs inversus. You could have a more frequent association. Furthermore, since the situs we are dealing with is not just atrial, but also visceral situs. If there is situs inversus of the viscera and the heart is on the left side, that's isolated levocardia, wherein majority may have cardiac defects. Likewise, the heart may be on the right side, and yet you have situs solitus of the atria. That latter one, dextrocardia with situs solitus of the atria, suggests to us that the position of the heart does not mean that there is that it could be associated with the specific type of situs.
So it's basically, once we decide the situs is for the extracardiac, for the intracardiac, but also not to forget the extracardiac anomalies that could be associated, whether it's totalis or parture or whatever. Also, if this is syndromic or non-syndromic, is this correct?
Yes, especially if you get to identify abnormal structures that you think could be associated with particular genetic anomaly.
Okay, we have a question here. How early you can determine the situs in gestation, and what is the value of that?
The value of determining the gestational age?
No, the situs, we just answered this question. The second one, how early you can determine the situs?
Oh, okay. Lisa Homberger would say that she can determine it by using the transvaginal ultrasonography, but in transabdominal fetal echocardiography, you could look at it at 16, 18 weeks age of gestation, wherein the heart may already be identifiable, especially its parts. But likewise, also, you have to think of the size of the heart and the amount of amniotic fluid. The amniotic fluid usually increases dramatically by 22, 23 weeks age of gestation. So majority of the centers would prefer early 20s.
Dr. Shawi, as an obstetrician, maternal fetal specialist, what would you say about this question? How early you can determine the situs in pregnancy?
Do you hear me?
Yes, we hear you.
Okay, great. Well, it depends on what do you define as a situs. To see the IVC and the aorta may be tricky before 12 weeks. But if, however, you have, let's say, previous history of, let's say, azomerism, you can start at 10 weeks to see the stomach on the normal, on the other side. It's a question of what is the background. If you don't have any anomaly, it's quite tricky to see then there is any situs abnormalities. But the stomach and heart position may be seen very early, 10 weeks and even earlier. So, but if you have seen, let's say, an AV septal defect, and the stomach's on the left side, it's quite tricky to identify whether it's right or left isomerism.
Yeah. Okay, great.
You need transvaginal ultrasound, yeah.
Yeah, but nowadays with the transducers that are so advanced, maybe this is what Dr. Carvalho would say, that she hardly does any transvaginal ultrasounds nowadays with all the probes that we have and the frequencies.
Yeah, it's possible early gestation. So, the question is always, let's say, the absence of an IVC is quite easy if you get the sagittal view to see that there is IVC or not. But, to do it on a routine basis is not so obvious. And more difficult is if you have a stomach on the left, the heart on the left, and you see a single ventricle to say, well, this is a right isomerism because there is a juxtaposition. So this is really tricky, but it's possible. So it's the.
Yeah, thank you. So, okay. It's not just one thing that we go, if what I'm trying to say, Dr. Shawi, if we don't get the situs right as an early gestation, you have other things that will guide you in counseling. You have the NT, you have other things from the obstetric point of view that you'd say, oh, I'm not sure, but this and that might help you. The amount of amniotic fluid also could be a limiting factor for the image and so on. Is this correct from the obstetrician that yes, you can, but it's not easy, and also there are limitations, but it's not the end of the world if you cannot determine the situs in early pregnancy. Is this correct?
Yes and no. Let's say, let's consider the three groups. One group is the complete situs inversus. if you are scanning only vaginally, you will miss it definitely because it's really difficult to orient it where is right, where is left. And even by abdominal probe, it may be tricky in some situations. I've seen it in the early gestation, but to say it is routine is not the issue. Then there is a group of left isomerism where you have an IVC interruption. This is something where if you are focusing on, if you see some, let's say, AV block with high drops, you will see it. So, but if you don't have a hard block, you may miss it if you are not focusing on it. The counseling in right isomerism, where you have an association with an abnormal lung vein drainage, may be very important to seek for the situs. So if I see, let's say, the dextrocardia with the stomach on the left, and instead of saying, oh, it's partial situs inversus, I have to challenge and to try to see, even if I book the patient back at 15, 16 weeks to see if there is abnormal lung veins, let's say the vein confluence behind the heart. This is the reason. Otherwise, it's only a question of definition. It's for me rather not to classify, but rather the association of findings and for counseling. It's bad to counsel an AV septal defect as down, and it's the end of the day in left isomerism without relationship down. So this is the reason, not for classification.
Sure. Now we have lots of questions on the situs as well. Ernie and Dr. Shawi. Now, as an obstetrician and as a pediatric cardiologist, we have two ways of, I mean, the way you run the probe, the way you say right and left. Now, Ernie talked about the Cordis method. Do you use this, Dr. Shawi, or how do you determine situs from OB point of view? Because I think you do it differently. We lost you. Unmute yourself.
I learned this from Jimmy Huta when in his classical paper of 82, when he was very, very, very young. And this is the approach on the upper abdomen. And occasionally, in doubtful cases, I try after 22 weeks to seek for the atrial appendages, but this is more tricky. So question to Ernerio, what do you behave if you have a, let's say apparently isolated interruption of the IVC with azygos? When is it an isolated finding, and when is it a left isomerism with no cardiac anomaly?
Ernie?
Isolated interruption of the IVC, the posterior interruption, is quite unusual. And it is something which would trigger you to study in detail the fetal cardiac anatomy to make sure that you're not actually dealing with left isomerism or situs inversus.
Okay.
We can ask Dr. Huta, the father of the whole discussion, my mentor and other people's mentor. Dr. Huta, how would you determine right and left and the situs in a pregnant lady? Do you follow the Cordis? I know you don't, but I'm just asking. What do you do?
Well, thank you for that chance to listen to this discussion and to participate. The simple positioning of the aorta and the IVC, like was mentioned by Robbie, will take care of 98% of your difficulties. So our sonographers usually do that early on in the process. After they've oriented, they know which is left, which is right. They'll try to do that type of transverse scan right away and pick up on problems. Now, you know that some types of problem like omphalocele can lead to obstruction of the normal IVC, and you'll have an azygos continuation in patients like that. However, you can usually find a remnant of the IVC coming up and receiving hepatic venous connection, so that the diagnosis of left atrial isomerism is total anomalous hepatic venous connection, either by one or two trunks to one or both sides of the heart, of the atria. So I think that the first thing you'll see in those patients is that somebody will say, well, gee, the heart's on one side and the stomach's on the other. So that right away has got you into the realm of isomerism, and you're looking then at the venous connections to help you. I think the right isomerism is really important just to answer one of the questions in terms of association with asplenia also, because that really changes the long-term prognosis after birth. So we kind of think that getting that and nailing that with the presence of a strand or bilateral atrial appendages like Ernie mentioned, or typical other anatomy, or the IVC and aorta running together on either side of the spine, like is a classic finding, very helpful, I think, in the counseling and necessary. I think to omit the presence of asplenia and think that you're going to fix the heart and everything's going to be fine is really not very accurate counseling.
But also, why did they change the name from left atrial and right atrial isomerism to heterotaxis? Is there a philosophical reason behind that? Now we call it heterotaxis syndrome.
Yeah, well, I think I'm just kind of a practicing fetal doctor, and I just like to kind of get the right answer most of the time. So I don't think there is such a thing as partial situs inversus. That's something that came out of Texas 40 years ago and is just flat out wrong. So let's try to stick with Bob Anderson's original suggestion, which is there really only 4 types of situs. That'll get you through about 98%, 99% of the cases that you're going to see. And if you see one case that has a pulmonary artery discordant with the atriovisceral situs, it'll be quite unusual, and you'll have to sort that out after birth anyway. So I think your prenatal diagnosis of situs shouldn't be made more complicated. It should be as simplistic as possible. But you're right, we don't want to miss cases where the IVC is interrupted, or where the aorta and the IVC run together. One comment is that if you ever see a descending aorta on the right and it continues down into the abdomen on the right, that's got to be right atrial isomerism. That's the only morphologic place where a right descending aorta doesn't pass back over to the left. It stays down on the right, that's right isomerism. So there are other clues to help you.
That's true, Jim. But what I've been following is the fact that one has to identify, instead of labeling a global diagnosis, identify each part of the heart, each of the segments. And of course, we know that that right aortic arch, in majority of situations, cross the midline and go on as a left descending aorta. Although those who come down as a right-sided descending aorta, as you said, is a clue that there is something going on inside the heart.
But one case, I think, Dr. Hood, remember, if there is an interrupted IVC alone, it's still counted as isomerism, right?
Well, interrupted IVC can occur inside a Situs, but almost always you'll find a small IVC present that receives hepatic venous connection. The hepatic venous connection directly to the heart, as you see in left atrial isomerism, is quite typical, I think, and usually is not going to be confused with lateralized situs. So I think that, on the other hand, I'll hasten to say that in left atrial isomerism, one can have almost a completely normal intracardiac anatomy. You'll have an ASD up high over in the sinus venosus region sometimes, or almost a normal fossa valgus without ipsilateral pulmonary veins at times as well. So if we kind of hang on to the potential for left isomerism, it's important because those patients have about a 20%. Many have malrotation and many need surgery in the 20% need surgery in the newborn period. They have a potential for heart block, as Ernie was talking about before, or SVT. So I think you have implications of making the right diagnosis of isomerism.
The question in counseling, if we had a case like that, if there's only interrupted IVC in the heart, would you counsel them as isomerism or not?
If I had total anomalous hepatic
no, just interrupted IVC.
Well, if you have interrupted IVC and no IVC whatsoever that's identifiable, and the hepatic veins connect directly to the heart,
Yeah.
That's left atrial isomerism, of course.
I remember you told me that, and the family went and terminated just based on this, just an isolated findings, because probably also of the extracardiac lesions. We have a question for Ernie, and we have a question from a lot of sonographers. Is it important for the sake of teaching, this is for all panel, to really for the sonographer to go on trying to find the situs or not, for training purposes and for accuracy?
Oh, yes, definitely. To determine the situs?
Yes.
Certainly, because of the implication of having an abnormal situs seen in your fetal heart that's being interrogated. Okay.
And the second question also for Ernie, you have shown a beautiful slide. If you could go back, they're asking a lot about the secondary dextroversion. You've talked about dextrocardia and cytosaltus. If you could go back to that slide, that would be great, and tell us more about the secondary dextroversion or dextrocardia. I forgot what this thing said. It was at the very beginning, Ernie.
Yeah, this one? Yeah.
Yeah.
I understand that there are many nomenclatures in the literature proposed by many institutions and pathologists and cardiologists. But I've been following the fact that dextrocardia just means that the fetal heart is mainly at the right side of the heart, of the chest, I mean. But about 1/3 of normal fetal heart would have the mass be on the opposite side, but in 2/3, this will be on the right side. Now, dextroposition to me is when the apex is pointed to the left. Actually, I usually prefer this as secondary dextrocardia because it is assumed that the heart was just shifted to the right by pathology on the left side, such as diaphragmatic hernia or CCAM. And dextroversion is when the apex pointed to the right. This primary dextrocardia, this is the one that is mainly associated with congenital cardiac defect. Now, of course, in dextroposition or secondary dextrocardia, you could have cardiac defects, especially in the left side. There could be a higher incidence of hypoplastic left heart syndrome or LV hypoplasia. Now, of course, like any heart, there could be any congenital cardiac defect regardless of where the heart is at.
Dr. Shah, would you agree to this nomenclature as dextroposition, dextroversion, primary and secondary? Do you use this as in your practice?
Yeah, almost yes. Let's say what I think Bobby Anderson said was in one of his chapters, that ideally, and this is what Ernie is trying to tell us, ideally you should describe the heart position and the heart axis. And in most cases of what is calling true dextrocardia or primary is that the heart axis pointing to the right. Yes. Whereas the other one is pointing to the middle or to the left. Now, in pediatric literature, the first group is almost absent because you don't have a, let's say, a study on, let's say, outpatient in unit of pediatric cardiology where you have a diaphragmatic hernia and the child is running with the heart on the right side, or pleural effusion and or CCAM. So these are the perinatal cases. You know, this is why let's say the ideal way to tell people, in my opinion, is let's say try to understand what's going to happen to the situation if you do surgery. If you have a diaphragmatic hernia or pleural effusion and remove the left-sided lesion, the heart will come back. It is only shifted, as you're saying, shifted to the right side. However,
so you basically go by the apex. You just simply go by the apex and see where the apex is.
But also logically, every heart shifted to the right side, either because of the lesion on the left, or very rarely in scimitar syndrome or right lung agenesis, it is, let's say, sucked to the right side. Then it is a dextro position, whereas if the heart embryologically during the rotation is turned to the right because of wrong rotation, then it is the dextroversion. I think this is a good approach.
Do you use cordis? Ernie, sorry, yes.
There may be it may not possibly be completely true that correction of the left chest pathology will move back the heart to the left side. Especially since the chronic situation in utero would have the left lung being hypoplastic already, and especially the left pulmonary artery, and also sometimes repair or evacuation of the viscera, pushing it back to the abdomen, makes the left chest cavity be filled with serous fluid in many situations.
Yeah.
But this is not the usual, Ernie. I mean, then we go back and say, depending on what's in the hernia, right?
Yes.
Depending on what's filling the chest and the prognostic factors for the disease itself, with the lung volumes and lung expansion and all that. So most, if it is not a serious one, I mean, I don't know, probably you have a score for that, Dr. Shawi, that you can say, okay, I think the heart will go back to its position once we repair the hernia. And here you say, no, I think the lungs are not going to expand. And even if we correct it, the position of the heart will not go back to normal. Is this correct?
Dr. Shawi?
Let's say, I don't know, but if you have a left-sided diaphragmatic hernia and you operate it, the heart will be completely shifted to the left because the left side is smaller. The right side is quite good.
No, we're talking about right or left. Ernie's saying that sometimes, even after you repair the defect in the chest,
but
the heart is not.
But even if you have some, but if you have a large cystic lesion, it can be possible. But it depends on the findings. So
it depends on the disease.
Like
do you use Cordis, Dr. Shawi? Do you use Cordis method or you don't?
What is the Cordis method? Is the this one here, or what is the?
Ernie.
What do you mean by Cordis method? I lost you.
She means the Cordis technique of imaging that I mentioned earlier. Rima,
I do the axis, the size, and the axis, the position and the axis. Draw a line, left, right, and you see the cardiac.
And then you go 90 degrees clockwise.
Yes.
So, Rima, you mentioned that in patients with left chest occupied by cystic mass or by a diaphragmatic hernia, it's very important to identify what is the volume of the left lung that's normal by MRI. Another thing also is that I mentioned briefly that it could be associated with hypoplastic left heart syndrome. And the association of hypoplastic left heart syndrome with a diaphragmatic hernia or CCAM creates a very, very bad prognosis. In Toronto, a report several years ago, there's a 100% mortality.
Ernie, now this is also for our colleagues and junior colleagues. If you have a left, I mean, there's a difference between compression of the left side.
You're breaking.
Hypoplasia of the left ventricle.
I think we missed several of your statements, Rima.
Ernie, I'm saying for counseling, when you see a small heart with a diaphragmatic, a small left heart with a diaphragmatic hernia, the question is that, is this compression or this is hypoplastic, or is this hypoplastic?
Actually, you could, it's very difficult to determine because we know that, well, one could say that there's a degree of heart being pushed to the right side. Some of them may be just in the middle, and we could say that the pushing is not severe. Now, the volume of the left ventricle may be associated with the fact that only a small amount of blood cross the foramen ovale to let the left ventricle develop by itself.
I also, if you look at the heart and you see that the ventricle is apex forming, so it's more, and there's flow, and you look at the mitral valve and you find that the mitral is opening, the aorta is opening, and it's just a small, you would go more towards being compressed rather than it's hypoplastic. I would say so. I wonder if you agree to that.
It's so hard
Can I
to
just
say.
comment?
Yes, please, Dr. Huta.
Yeah, I think I agree completely with what Ernie was hinting at, which is that the heart, the atrial septum is displaced so that the flow of blood from the IVC and left-sided hepatic veins doesn't reach it normally. Therefore, you have an underfilled left side. There's no compression going on there at all. You can't explain the smallness of the left side just on the difference in pulmonary blood flow. That doesn't add up. There's no mathematically, but there's no doubt that deviating the atrial septum so that blood doesn't enter the left atrium, just as he suggested, is almost certainly the reason. An underfilled ventricle that is then nice and normal after you fill it back up again.
So how would you counsel it? Is this a hypoplast or is this an underfilled ventricle?
Absolutely not. It's an underfilled left ventricle as long as it's apex forming. It has nothing to do with hypoplastic left.
So Ernie was saying that the counseling could go for a left hypoplastic heart syndrome, and the prognosis is very bad if it's an associate. I would say it's a spectrum. So you have to check the aorta, the arch, the mitral and annulus and all that.
Yes,
Yeah.
As usual, we always agree there, Rima.
Yes.
A real mitral LV atresia, aortic atresia could occur in that situation.
Okay, thank you so much. We have to move to the next speaker. I'm so grateful to all the panelists and the speakers. Now, our next speaker is Dr. Bree-Ann Muller, and she is working at Rush Medical College, and she's also the program director of the Pediatric Cardiology Fellowship at Rush. She's also an assistant professor of pediatric cardiology. She has a very interesting topic. Bree, would you be kind enough to start and share your screen?
Yes, of course. Can you hear me?
Yes, we do. Thank you.
Perfect.
Ernie, could you go out? I mean, close your...
Okay, how's this looking?
Great. Just the presentation mode, please.
There we go.
Thank you.
Okay, so thank you so much for the invitation to speak today. I'm going to be speaking to you about the foramen ovale in fetal circulation and a couple of the abnormalities that we can see. I have no disclosures. So I just want to point out, we owe so much to Dr. Rudolph and Dr. Hyman, who did the initial research on fetal lambs starting in the 1960s. And it's because of his research that we know so much about the way the blood flows in the fetus. This diagram on the right is from his publication in 1985 that showed the percentages of the cardiac output in different parts of the fetal heart and the arch and the duct and the lungs. Here's another diagram from Dr. Rudolph. This specifically shows you the flow coming from the placenta, which is here, the umbilical vein, and the dashed arrow, the black and white lined arrow, is the oxygenated blood. And you can see some does go across over to the portal system, but the most goes through the ductus venosus and then through the foramen ovale here. And that's with the help of the eustachian valve. And we know that about 40% of the oxygenated blood that comes from the placenta does go across that foramen ovale. So I just want to mention a couple of terminology points. I'm going to abbreviate foramen ovale with FO for most of the talk. I'm going to use the term the valve of the foramen ovale, which is actually the flap. This is septum primum. And sometimes we use them interchangeably. I know I do. When we're referring to the foramen ovale, we're referring to this flap. And technically, the foramen ovale is the opening that the blood goes through. But it's very common to use them interchangeably, and I'll probably do that today as I'm talking to you. So normal findings is what I'm going to start with. So the normal foramen ovale flap should be thin and mobile. It should show a biphasic motion on M mode, and I'll show you that in a minute. It should extend into the left atrium with some intermittent motion back towards the right atrium. Its normal angle is about 30 to 50 degrees if you consider it as an angle from where it hinges off of the septum, the bottom inferior portion of the septum primum into the left atrium. That angle is about 30 to 50. The flow should be non-turbulent by color, and the normal velocity is around 40 centimeters per second, plus or minus about 12. And it should have a triphasic pattern on the velocity. So what is normal? I think, I think we don't pay a lot of attention often to the foramen ovale because it's usually normal, and we don't, routinely measure it with every study. I have to say we don't, if everything looks normal. But Kleinman did a nice study in 1991 that showed the ranges of normal foramen ovale diameter. And I'll show you what that means, where we actually measure that diameter. But of course, earlier in gestation, it's going to be smaller. And then as the fetal heart grows and the fetus grows, the foramen ovale dimension will grow as well. And it'll reach out about to half a centimeter in the third trimester. Other things to consider is that the foramen ovale dimension is about a third of the atrial septum. And the foramen ovale is about a 1-to-1 relationship with the aortic valve. So this is what I'm talking about when we refer to the foramen ovale diameter. It's this red line here. So this is anterior, this is posterior, this is a fetus at 26 and 4. And so this is left atrium, right atrium here, RV and LV. And so this kind of where we get the dropout, right, in the atrial septum, that's where it's traditionally been measured as the foramen ovale diameter. And the ideal echo views to make this measurement are in the forward chamber, as I showed. Also in the sagittal views, the bicaval specifically, and then the sagittal view of the aortic arch. So here's a nice forward chamber image. This is the same picture I just showed you, but now in video, 26 and 4. So you have descending aorta here, here's spine. This is left atrium, right atrium here. And I like this image because, as we all know, we don't always have a perfect picture. We often get shadowing from arms and legs and things. So initially you can see a little bit more crisp image of the foramen ovale opening here. Then you get a little bit of shadow, but you can definitely make it out right there. And then the flap is moving nicely in the left atrium, intermittently goes towards the right, but mostly stays on the left. And so I just want to mention Doppler. So Doppler, I feel like, is not very reliable, specifically with the foramen ovale, and that's been mentioned in many studies that I saw published as well. So it should have, mostly right to left flow. So here's our baseline down here, and this is the same fetus that I just showed you. So right atrium here and left atrium here. So it's mostly right to left flow, and there may be intermittent left to right briefly, but of course it's mostly right to left flow. The velocity should be less than 40. And I'll touch on this a little bit later, why I think sometimes the Doppler is not as accurate. And then this is a nice M mode depiction of the foramen ovale motion. So again, the same fetus that I showed you before. So this is the right atrium. The red line is pointing towards the foramen ovale motion. This is left atrium here. And then this is the left ventricle mitral valve, kind of where they meet. And this is systole, and here's diastole. So you can see in systole, the foramen ovale flap has two little bumps towards the right atrium, then comes back down and is mostly sitting towards the left, and has again two bumps towards the right and back towards the left. So that's a nice normal M mode pattern, and something I think can can be done more frequently. I have to say we don't do this, you know, in every patient, but I think I might start doing it more. So here's a different patient. This is a 30-week and 3-day fetus. I like this sagittal view. You can see the IVC coming up through the liver here, right atrium, left atrium, and you see the flap. It's mostly in the left atrium, occasionally goes and touches the septum secundum here. And initially in the sweep, you see that SVC coming down, and then it's aortic arch that comes into view. So that's a nice normal foramen ovale. And then this is the same with color. So you can see nice red flow coming up initially towards the transducer. And it comes up and across the valve and becomes blue. So those were the main points I wanted to touch on with the normal findings, the flow, the M mode, what it looks like by 2D. And then now I just want to transition over to some abnormalities that we see with the foramen ovale. And mostly I'm just going to talk about restricted and redundant foramen ovale. And I'm going to focus on structurally normal hearts. Of course, it's been described, you know, many times in the context of transposition and hypoplastic left heart. And of course, it's very important in the context of those things. But today I'm just going to focus on a structurally normal heart with a restricted foramen ovale. So I'm going to use the abbreviation with a lowercase r and then FO for restricted FO. So it's an infrequent finding. It's about a 1% incidence in normal hearts. This has been quoted in many studies that I found when I was doing research for this topic. Although, you know, it's likely that this is probably an underestimation. And I say that because, you know, most of the time this is found in the 3rd trimester. As I show you there, one study showed a mean gestational age of about 33 weeks. So if moms aren't getting a scan in the 3rd trimester, which many times they don't, and then these babies usually do well after delivery, if it's just a restricted foramen ovale, it's not found. So I think the 1% incidence may be an underestimation. And then I'll also mention there a nice study that I read showed that in cases that were referred for a dilated right ventricle, a restricted foramen ovale was found in about a quarter of those cases. So when we're referring to a restricted foramen ovale, sometimes we use the terms of being hypermobile or redundant. So it's thicker, it has extra tissue. It's also been described as tense or fixed, so it's not moving as much. The left heart structures are going to be on the smaller side, and the right heart structures will be on the larger side, including the pulmonary artery and the ductus. And at the end, I'm going to touch upon this finding of a posterior directed ductus that's been described with a restricted and a redundant foramen ovale. And of course, the main concern is that the arch often looks small with these cases, and specifically the isthmus. These babies are at risk for arrhythmia, whether or not it's related to the redundant tissue or dilation of the atria, it's unclear. And sometimes hydrops can be seen, and these are really the most severe cases, and usually those that are complete closure or early closure of the foramen ovale. So accepted definitions based on many studies are a few outlined here. So this now I'm referring to a restricted foramen ovale. So if the diameter is less than 0.3 when comparing it to the right atrium, when comparing it to the aortic valve, if it's less than 1/2, less than 0.5, and remember the normal ratio is about 1:1 to the aortic valve. If the foramen ovale to the atrial septum ratio is less than 1/3, if the Doppler is over 40, or if the diameter of the foramen ovale itself is less than 2.5. So here's a nice example that we had. This is a 34-week baby. So here, posterior is here, spine here. Here's your descending aorta. Left atrium here, left ventricle, RV, RA. And you can see initially the size discrepancy between the ventricles. Now at a 34-weeker, the ratio of the RV to LV should be about 1.2. So this definitely looks larger than that when comparing just the RV to the LV at the annulus. But you can see the LV does look like it's going down to the apex. And then the notable thing with the foramen ovale is that, it's definitely in the left atrium here, but it's really not moving. If you recall the normal example that I showed you in the first few slides, this foramen ovale looks very tense and fixed and not very mobile. So here's a Doppler of that same patient, and this is partially why I think the Doppler may be less reliable, because here we're getting, velocities around 40, whether or not this was a perfect, envelope, that can be debated. But I think, and many studies have mentioned this as well, that the Doppler can be misleading and maybe not as reliable, just also because the fetal, echo imaging for us can be tricky to get the perfect angle. But this was a nice still of the same foramen ovale. So this is left atrium, this is right atrium. So this is the flap that's kind of bowed over into the left atrium. And we can see that there was a jet of red flow coming right through an orifice here within that flap. So we realized that really there was not normal forward flow across the whole foramen ovale, that the flow was restricted to this very small opening within the flap. And this is something to note because the diameter of the actual foramen ovale here, which was the traditional measurement point, would be considered normal. And this is the arch for that patient. So we were, of course, concerned when we see this aliasing in the arch. So this is anterior chest here, posterior spine. By 2D, the arch really doesn't look too concerning, but the color flow pattern was more concerning for us. So this is a second case, a different fetus. This is a 33-weeker when we saw her for the first time. And you can see this foramen ovale flap looks a little bit different than the first case. It's more mobile. It's not as tense or fixed. But you can, I think, appreciate there is some size discrepancy with the left side versus the right. And this is that same patient now, a short axis view, where you can see the foramen ovale motion, that it is within the left atrium, but at times it moves towards the right and bulges a little bit more towards the right than maybe you would expect. So this is right atrium. Here you see IVC, the eustachian valve here showing nicely, and the flap of the foramen ovale here. And this is that same patient. I just want to show this sweep, which showed how dilated the pulmonary artery was for this patient. So here initially the red flow here, this is pulmonary valve, this is RV, and that's the forward flow across the pulmonary artery. Here's aorta here. And then this was also the same patient. We were, of course, concerned by the arch flow here. So seeing this red flow in the arch, concerning for reversal, we were really concerned, is this going to be a coarctation or is it just restricted abnormal foramen ovale? That was at 33 weeks, though, the one I just showed you. Now we brought her back at 37, and here you can see the arch looks better. Still some aliasing, but overall it didn't show that reversal. And by 2D looked like it was going to be okay. So the final points I just want to talk about are this really unique finding of a redundant foramen ovale. And I found this nice publication by Palladini in 2020 that described a redundant foramen ovale flap. And this is separate from the restricted foramen ovale. And what they found in this study was that the foramen ovale flap diameter, when you compared it to the left atrial diameter, if it was greater than 0.65 ratio, this was associated with ventricular disproportion with a significant p-value. And this association was independent of if the foramen ovale was restrictive. And restrictive definition using like the 5 points that I showed you on the earlier slides, based on the measurements, based on the Doppler. And they also, of course, saw that there was definitely multiple cases of reversal of flow in the aortic isthmus with a redundant foramen ovale that ended up not being coarctation. So this is how they measured a redundant foramen ovale. So again, the same foramen ovale diameter here with the green line. And this is the left atrial diameter, as you would expect, the blue. But the foramen ovale flap diameter, they measured from the atrial septum where you would expect it to be, and basically how far did it go into the left atrium. So a ratio of 0.65 or greater was definitely associated with ventricular disproportion. And this has also been referred to as an atrial septal aneurysm if it extends more than 50% in. And one study mentioned that a redundant foramen ovale flap was seen in about 1/3 of cases of restrictive. So sometimes they are seen together. You can have a redundant flap that's restrictive, but a redundant flap doesn't always mean it's going to be restricted by flow. And let me talk to you a little bit more about that and show you some examples. So this was a really nice case that we had, again, a 33-week baby fetus that came to us. So there's definitely a trend with this timing in the 3rd trimester. So you can see livers over here. This is your descending aorta. So this is left atrium, right atrium. And here's your foramen ovale flap. And it just appears to be more redundant, a lot more tissue than we saw in those initial slides when I was showing you what a normal foramen ovale looks like. There's just more tissue there, and you can see it kind of has this serpentine-like quality and looks just different. Here you don't see the ventricles as well, but I'll show you coming up. So we brought her back at 37 weeks. And again, you can see the flap is in the left atrium. This view, whether it was the view or with time, the foramen ovale did appear to be, maybe there was less tissue there, but still looked like it was mobile nicely. It didn't appear restricted. There's nice right to left flow across it. But there was, some size discrepancy with that LV and LA just appearing a little bit on the small side. And here was the arch for this patient. So spine here, so transverse arch here, ascending and descending. And so the transverse arch, looking at that, definitely had us worried. But this patient and the next patient has this interesting finding, I think, of this posteriorly directed ductus. So when the ductus enters a little bit more posteriorly at the descending aorta, right below the isthmus, it often can give this impression that the isthmus is small, but when you measure it, it measures okay. And I think some cases it's because of the posterior ductus, not always. And then this is the last patient I just want to show you. I thought this was a really nice example of a redundant foramen ovale. This patient was actually referred, there's a small muscular VSD for this patient, so that's why she came. The size, there really isn't size discrepancy at this point, and she's about 33 weeks. So I thought that was interesting to compare to the other ones. But you can see here, so this is left atrium and this is right atrium. And you can see the tissue of this foramen ovale is pretty much touching the side of the left atrium there. And it's really also getting very close to that mitral valve. Some, atrial septal aneurysms have been described to even cross over the mitral valve. This doesn't look to be the case here. And then here's the arch for that patient. So again, I think it has this very interesting finding of a posteriorly directed ductus that kind of makes the descending aorta look a little bit more protuberant or bulbous in that area. And let me show you with color flow what I mean by that. So here, the ductus is coming over here, the red flow. The aortic arch is coming up here, this red. So you can see where the ductus enters a little bit more posteriorly. It gives that appearance that the isthmus may be small. This isn't always the case, but I've seen that, and Palladini did mention the same. So I thought that was interesting. It's something that I hadn't thought about before. So overall, the prognosis is generally very good for babies with a restrictive or a redundant foramen ovale. There is a risk for arrhythmia. Usually that's just in the neonatal period and nothing that's going to persist. There are cases that have been described with pulmonary hypertension, but those babies usually do well, and we don't know exactly the mechanism behind that. And most cases of the redundant foramen ovale, they do close. They don't become atrial septal defects. And as I alluded to before, these are not coarctation. So all those cases that I showed you from the beginning, none of those patients had any issues with the arch. And here's a postnatal. So a nice view of right atrium, left atrium. And this was that first redundant foramen ovale that I showed you. So you can see it looks like it's nearly closed up. It has a little unique kind of feature there with this little bit of tissue still on the left side, but it doesn't look like it's going to be an ASD. And then here's the arch for that patient. So this was the fetal that when we saw her at 37 weeks, the isthmus still looked concerning. But then look at this beautiful arch that we had on the baby. So it's just amazing how things can transition after they are born. And I just have this last slide just to say, to summarize, the foramen ovale, there's well-established parameters for what is restricted. I can go back to that slide where it kind of laid out all the ways to kind of define a restricted foramen ovale. As I mentioned, I think some are more reliable than others. A redundant foramen ovale may mimic a restricted, so it's not going to look like the flow is restricted, but there is some impedance to the flow across the mitral valve and the growth of the left ventricle. But usually these all, after a baby's born, there's no concern with the left side being small and the arch is fine. And that's something to consider if you see cases that appear like coarctation, but you definitely are concerned about that foramen ovale being restricted, then it's probably less likely going to be an issue with coarctation. And those are all my references. So
thank you so much. Thank you so much, Bree. Could you go back to the slide where you put the definitions of restricted versus redundant, please?
Yeah. Just going a little slow.
I can see Dr. Huta wants to talk, so I'll let Dr. Huta talk before
I will love to hear any expertise he has to say. There was this one, but I think you meant the other.
No, I meant the ratios and the measurements.
Yeah. Let me show you. I don't want to exit out.
I love the talk, Dr. Mueller. That's very nicely done, and a topic which should be just simple as pie, but in fact, it's quite complicated as you get into it.
I know.
Yeah, I wanted to ask what the panelists think of the terminology and the impact that Bree spoke about, the value of ventricular disproportion, the possibility of coarctation, the reversal of flow and the isthmus. All this comes with the ratio. So, Dr. Huta, you are the flow man. So, what would you say about that?
Well, this is the real difficult area in fetal cardiology, I think, this whole coarctation business, because we could have pulled coarctation out of several of your cases there. We would have done a coarc watch on most of those, after birth. If we do 6 or 8 coarc watches a year, we're happy and we'll get 1 or 2 coarcs out of it. So, but I wanted to make a couple of points. One is that this term of restriction, if there is restriction at the foramen ovale, then the right atrial pressure should be elevated, especially in atrial systole, and we should see that reflected in the ductus venosus waveform. But we wouldn't make the diagnosis of restriction at the atrial level almost in any heart defect or in normals unless we were seeing that kind of a finding. That will restrict us to those which really have hemodynamic significance. Then I really liked this definition as far as the disproportion and such, but the one comment I wanted to make was about a reversal in the aortic arch. You know, for years, people, my techs have been telling me, oh, when there's reversal in the aortic arch, that's coarctation, and there's confusion about it. And I think we finally understand this now. I learned several years ago after a very nice talk by a South American cardiologist. He showed clearly that the reversal in the aortic isthmus is late systole. It's late systolic reversal. And this is a consequence of the disproportionate stroke volumes. When right ventricular stroke volume is higher than left, flow continues in late systole and goes in reverse very briefly. That's going to be true of any disproportionate flow situation. Has nothing to do with coarctation of the aorta. Now, it may coexist in coarctation, but I wanted to mention that that confusion, I think, now is in a sense been cleared up, so that you that's another good reason not to use Doppler to make the diagnosis of cohort.
Yeah, I always thought restriction means Doppler. And I just want to add one thing, Dr. Hutter, you taught me also the IUGR with the aortic isthmus, right?
See, that's diastolic flow reversal, and because of brain resistance, falling. Yeah.
Okay, so also, Bri, this is beautiful, but as Dr. Hutter said, that you did not show a lot of Doppler with the term restricted. So either you will have a difference in also in the pulsations in the foramen valley flow and Doppler, and also color aliasing, which we did not see in any of the restrictions you've showed. Actually, the color was okay.
Right, and I mentioned that, and I don't know if it was us in particular, but I couldn't find any good high velocity flow patterns from ours that were clearly restricted, but maybe we weren't capturing it at the right angle. But I think you mentioned a good point about the ductus venosus. And, that was nowhere in the accepted definitions, and it should be. But I think maybe nobody's come up with, or maybe you haven't, I don't know, like what the velocity would be, how you would define it. But you're right, I didn't even put in anything about the ductus venosus. I didn't see that as much when I was researching for this.
What about pulmonary veins? Pulmonary veins as well. I mean, when we talk about restriction, we always go back to pulmonary veins.
Well, that's in the left heart, with left to right shunting at the atrial, with a hyperplastic.
Yes, but this the term, yeah, I understand. But if you're going to assess restriction, you would say the direction of flow, the Doppler flow, and also you assess the veins that goes into right heart and the veins that go into the left heart as part of the.
depending on the direction of flow, like you say. So
you
look at the hepatic veins for atrial restriction in the normal heart, and the pulmonary veins. By the way, an aneurysm of the fossa ovalis can obstruct pulmonary venous return. So we have a couple of cases with pulmonary hypertension and reversed flow in the aortic arch in systole from some significant pulmonary hypertension.
Oh, wow.
Reversed after delivery, Dr. Hutter, or
if they had pulmonary hypertension which resolved after delivery.
And what about the numbers? Do you agree, Dr. Shawi? I mean, you're keeping quiet, but what about the numbers that we have here? Because I think this is beautiful. I mean, which one would you go for? The 0.3, the 0.5, the scepter ratio, the Doppler, the diameter? And what about the 3D nowadays? 3D is beautiful also, and you can get measurements in both planes. Dr. Shawi?
No, it's quite really. It's nice. It's let's say it can be interesting for publishing results because to define what is going on, but I'm not sure that these values are validated, that if value is less than 0.2 or more than 0.35, it has another outcome. This is why it is, in my opinion, arbitrarily definition to make a group A and group B. But actually we should go to the postnatal phase and see these one had this development and then these ones had this ratio. This is why it's nice. You can use what you want, but I don't know the true clinical impact of this. I do it more, let's say, by taste. Sorry to.
What about the ratio?
It looks like a large.
Yeah.
But I have a question to Jim. I never, to pediatric cardiologists, I never saw a core atriatum sinister. Can such a flap mimic a kind of coronary atrium sinister antenatally?
Well, that type of flap would be in the right atrium. You're referring to persistence of the right venous valve, right? Not a coronary triatum. You said dexter, so it's in the right atrium.
No, in the sinister. If you have a sinister one and you have some membrane in the left and you don't know it's a foramen ovale or is it a membrane?
Oh, okay. Okay, so if you have a coronary triatum, you can have several different types of coronary triatum membrane in the left atrium. One will come off the lower edge of the left lower pulmonary vein and extend all the way over to the septum, sometimes with a pretty small opening toward the lower chamber. Others can be somewhat redundant and non-obstructive. So I think that the fossa ovalis may relate to the upper chamber or in some rare cases to the lower chamber. So it's possible to have those two types of coronary triatum.
Okay.
But Dr. Shah is asking, could this mimic a redundant foramen ovale flap?
My concern is if we tell people, don't worry, it has no clinical impact because it's not a coarctation. At the end, this is the situation which is coronary atrium sinister at the end. So,
well, we worry about all cases of disproportion, and I think all cases of disproportion warrant a monthly evaluation up until the delivery, and then a postnatal cohort watch.
Yeah.
Thank you so much, Bree. A really beautiful talk and beautiful thought behind it. And I think a lot of the attendees will go and think about it. And I would rather take the ratio of to me at least, the ratio of the defect to the septum as we do if they want to do the devices. I think to me it's the easiest one. Do you agree to that, Dr. Huta? Or which one would you choose?
Well, I could make a lot of measurements. It would be a long run for a short slide, I think.
Which one would you choose if you were asked to, I mean, as part of practical?
I want to know if there's coarctation, okay? And that's what I want to know about. So I'm going to use the morphology of the arch and lots of other factors. When I see a foramen ovale aneurysm, I'm going to be pretty sure that 90% of those patients don't have coarc. But I'm going to check.
Okay, that's beautiful. Thank you. That's a nice. Thank you so much, Bree, and thank you for such a beautiful presentation. We have to move to our third speaker, who is very well known and my mentor and my co-author, Dr. James Huta, and he is very well known for the cardiovascular profiles core. I don't have to present you, Dr. Huta, because I mean everybody knows you, a professor of pediatric and fetal cardiology, and very well known for all his publications in hemodynamics. And I know that Dr. Huta is basically an engineer. That's why he's so good in fluid hemodynamics, correct?
Oh my goodness, I just made that transition from engineering to bioengineering to medicine. But I do see the fetal circulation as a system that has certain energy in it, and the distribution of that energy tells us a lot about what's going on. Are you ready for me? Oh,
Please, Dr. Huta, proceed. Thank you.
Okay, thank you. I want to be sure I'm on here. Thanks very much. It's great to be with you here today. Really setting the table. It was so nice to see all the nice work on the atrial septum and talking about the distribution and redistribution of flow around the patients with diaphragmatic hernia, for example. This is a language that very few people speak. And if you go to your adult or your congenital heart disease colleagues, pediatric cardiologists, only about 1 in 8 are going to have any idea what you're talking about. So this is a very fun club to be part of, with everybody speaking like that. And I appreciated Robbie's comments as well here this morning. Today I wanted to just give some basic observations about problems we can have with fetal Doppler in terms of making accurate measurements. Well, you might say, how often are we going to be doing an operation on a number, on a Doppler velocity? Not very often. And so I like to use morphology criteria primarily, but I want to point out some pitfalls in making quantitative measurements with Doppler. Also, I'll be emphasizing the ductus arteriosus in this talk. That'll kind of round out our look at the fetal circulation. Now I have to decide what happened here. Let me stop the share for just a second because something happened. Let's go back over here and make sure we get started here. Here we go. Oh.
Okay, just press enter, Dr. Huta. Enter it, it will move. You have the first slide and we can hear you, we can see you.
Yep, I'm trying to get him to move, but it's not moving. So it acts like I'm gonna have to go choose it one more time here. Hold on. So share screen.
Presentation mode, is it on the presentation mode?
Good question. Let's just see here. The slide from the beginning. Yeah, I'm in the presentation mode now. There we go.
Yeah.
Okay, I think we're good there. Sorry about
Thank
that. Again, just a summary of the complexity of this circulation we've been discussing here today. And here you see the fossa ovalis, you see the crossing arch, ductal arch, and aortic arch. And I'll be talking a little bit about assessing the velocities in the ductus arteriosus as part of a talk in how difficult fetal Doppler can sometimes be. Well, where are the problems in the use of fetal Doppler? I'd like to suggest that problems occur in the semilunar valve flow assessment, particularly of the pulmonary valve, because we don't have the landmarks, if you will, or the morphologic guides as to how to get in the right angle toward the flow. We'll talk about the ductal flows and the fact that they're rounding the corner, if you will, and you have to be tangential to the corner that they're rounding if you want to get the maximum velocity, and you've got to be willing to move back and forth with your Doppler probe to do that. Some days I think we do a better job of doing almost a blind Doppler with 2D rather than making us think that the color Doppler is showing us where we should be, when in fact it can be misleading us. And in ductal constriction, the same is true. You don't know what the angle of that accelerated velocity is. And so you always have to be thinking, this flow that I'm trying to assess, whether it be a high flow or a normal flow, is kind of like your arm, okay? And if you think of your arm as off in this direction, you can see it from one angle, and you know what the angle is, but you have no idea where it's going in the other angle. So a two-dimensional look at a three-dimensional flow is always going to have the potential for you to miss that third dimension, if you will, in terms of the angle of flow. Well, you've got to have it right in all three dimensions. You can be, quote, perfectly aligned and get exactly a low answer. So we're talking now about having blood velocities that are underestimated, right? I'm going to be mentioning some of these things here today, and the main thing is the bad angle. Okay, well, sometimes you just have a bad envelope and you can't measure very much. I'll show you one example of that. We can have diameter squared errors when we're doing flow calculations, as everybody knows. That this makes it quite difficult. I have to admit that after many years doing this, that we're not quantitating flow very often in the fetal heart, and as a result, we're not all that accurate in doing it. Unless we do a lot of it, we're not going to be reliable when it comes to quantitating AV fistula flow, for example, as has been suggested for cerebral AVM, for example. So I think that there's potential for errors, particularly in the diameter measurement. We'll talk about just briefly the pressure recovery phenomenon. As we see in post-op coarct patients, we know that there's a high velocity in the aortic isthmus where there's a mild narrowing, and yet we don't measure any gradient across that area. This so-called pressure recovery phenomenon is due to the tubular nature, the tubular morphology of the narrowing. Now, fortunately, most of the narrowings that we measure flows across are discrete, like an AV valve with AV valve regurgitation. Aortic valve stenosis is not going to be tubular, but some that are going to fool us by having a higher velocity than the actual pressure gradient is there. Finally, the sample volume, if it's too small, is just not insulating the whole flow. So I think I like to err on the side of a large sample volume for my any measurement of valve blood flow. Now, then I'll just finish by reminding you that the Bernoulli equation is actually a complicated equation that's simplified to this 4v squared that we use when we talk about gradients in the fetus. But remember, that has to be a discrete gradient. It has to go from big to small to big with a very discrete narrowing. If it's a tubular narrowing or a long narrowing, then we're going to get probably the wrong answer as far as a pressure gradient. Let's go forward and just look at some typical pulse Doppler tracings here. We know that the pulmonary valve, or the aortic valve and the pulmonary valve, have slightly different shapes. And if we want to do what's called a time velocity integral, we can integrate that waveform in order to begin to assess what the flow through that valve might be. Well, as you know, we have to do the mean of this time velocity integral, if you will, times the area of the flow that it's going through. So this requires that we make that diameter measurement, and it's always potentially an error, one way or the other, underestimate or overestimate. So you'll see a lot of scatter. Try sometimes yourselves, take a whole day of cardiac output measurements and then calculate them compared to normal, and you'll see that you're getting a pretty good scattergram. You're not getting real consistency, perhaps with the exception of the aortic valve. And I say that because the aortic valve has these landmarks in it that allow us to get pretty darn close on that third dimensional angle. The pulmonary valve, on the other hand, as I'll show you, is wide open for different measurements. This just shows some of those valve velocities in normal through the mitral, the E and the A waves. And you can see the kind of scatter that's going to be present in any kind of pulse Doppler evaluation. Again, if I'm looking at those things, I like to see a little bigger sample volume rather than a smaller one for most uses. Now, one other problem that can occur, this is a tricuspid valve regurgitation jet, and shows you an attempt at using continuous wave Doppler, which is what I always favor in looking at valvular regurgitation. If I want to know the peak velocity, but you see how it just kind of tails off, and you're not sure really where the peak is. You could take a guess at it, but you're going to need a better waveform than this to be able to sample. To actually make any measurements on the peak velocity of a TR jet. Well, a peak velocity of a TR jet is a discrete jet, and it will follow the Bernoulli physics, and you can get a pretty good estimate of right ventricular systolic pressure if you can get the envelope to look right. In addition, we can look at the upstroke of the TR jet and calculate dPdt between 1 and 3 meters per second. For example, on this fetus with a very high TR jet, happen to be a recipient twin and a twin-twin transfusion, you can get the change in time and the change in pressure calculation and calculate dPdt, which should be over 700 or so, 700 in the fetal heart. This happens to be an example of ductal constriction. We'll come back to that as an example of as a clinical application. So this is no surprise that you know that we're using the diameter of a valve and we have to square that number. So any error that we make in that diameter is going to multiply itself into the calculation of flow in cc's per second. And then that flow is usually adjusted for the size of the baby so that most of our errors using the diameter are going to be in the 10 to 20% range. And we sure would like to have an internal calibration. Well, what do I mean by that? So if you're measuring the aortic valve flow and you say, oh, look, I've got that, it's within 5% every time I do it, well, try comparing that aortic valve flow to the mitral valve flow on the same beat or the similar, a nearby beat. And that's your internal calibration. If you can make both of those flow numbers match up with each other within 10 or 20%, I think you're doing pretty well on volume measurement. Now let's talk about this pressure difference that can occur at the ductus arteriosus. This happens to be a PDA patient after birth, where a dynamic pressure measuring catheter has been placed into the main pulmonary artery and the femoral artery, and we're looking at the instantaneous gradient here, and then looking at a simultaneous continuous wave Doppler on the same beat which is measuring about 49 millimeters of mercury versus 56 millimeters of mercury. You can see here that the timing is very important, so that this is always the case, especially in aortic stenosis, where the timing of the peak is not the same as the gradient on a pullback in the catheterization lab. But we are using, I think, the Bernoulli equation correctly in most cases of ductal constriction. Most of them are discrete. The more tubular they become, however, the more chance we could have this pressure recovery phenomenon with a higher velocity and a higher gradient predicted. Now, use of non-parametric measurements is what we really would like to do, and that is the perinatologist is not going to appreciate you saying, oh, there's a 32 millimeter gradient, blah, blah, blah. They have no idea about that. Why can't we just say there's mild constriction, there's severe constriction, or that same way with valve regurgitation? With this, a non-parametric communication is going to be better understood amongst our subspecialty referring doctors. Now, we do want to optimize the angle, as I mentioned before, to maximize our velocity, but this requires that be willing to move the transducer looking at the waveform. And also, if you're optimizing a high velocity, make sure that you bring the wall filter up to get rid of the clutter or the lower velocities that are going to have no importance in the measurement. Now, again, use continuous wave Doppler for pressure gradients. If you don't have a machine with continuous wave Doppler or never heard of continuous wave Doppler, at least investigate that, because this is going to give you a lot better action when it comes to getting valve regurgitation jets calculated properly. Now, we know that the anemic patient can have high velocities or a high cardiac output state, such as in a high output, like we mentioned, the AV fistula type of patient. If you're wondering whether a patient is anemic, then go back to the Mari diagram, the Mari nomogram, I should say, and look at the peak velocity for gestational age, and you'll get an idea of whether you're dealing with an anemic fetus. We find this very, very useful, especially when everything is a little bit high on our velocities, and we're wondering if the anemia might be part of the problem. Now, these are data from several authors here, looking at a combined cardiac output. And as they say, the numbers, they kind of look good on the graph here, but there's a lot of play here, a lot of splay in the range of, 30, 20, 30% as you get up near later gestational ages. Same thing here, we're looking at a light blue, the faint kind of blue marks are the right ventricular cardiac output versus the left ventricular. And you can see that the right dominates throughout gestation. Here's the slide that was shown here earlier from Rudolph. And here's another look at more of the Rudolph data, all from the fetal lamb. So what he showed us was that there was really a very low flow in the lungs. And then we found out that, in fact, it's not 7%, it's not even 17%, it's closer to 20 or 25% in the human Doppler. And this was shown and quoted by Rudolph in his papers. Now, as we realize that Doppler measurements of the branch pulmonary artery Doppler flow, one can then calculate the foramen ovale flow. And this comes out kind of interesting because it looks like it changes with gestational age. 34% of the combined cardiac output across the foramen at 18 at 30 weeks and 18 or 19 at 38 weeks gestation. So this tells you what Bree was hinting at, is that right around 30 to 32 weeks gestation, things are changing in the fetal circulation. And that's sometimes when patients will fall apart because their foramen ovale flow has really dropped and they're very dependent on it in one thing or another. Pulmonary blood flow, as we mentioned, is about 25% of the combined cardiac output in the human fetus. And this has been validated by several different authors. Ductal flow drops down a little bit here. And this was nicely shown here by Rossinen and now confirmed by others. So let's go forward and look at some of the different kinds of shunting. This is the ductus venosus, for example, and the pulsatility index in the ductus venosus can change and increase in patients who are having a decrease in their placental venous return. We know that something as simple as a little constriction in the umbilical cord could actually change the blood velocity. So we have to look out for artifactually created flows, which are just because of the closeness of two vessels. For example, if you look at the venous Doppler waveform, notice how it's pulsating. Well, the pulsation in the umbilical vein is actually because it's being compressed along with the umbilical artery, and we have a transmission of umbilical artery flow into the venous flow. So just another example of something we don't want to be fooled by a pulsation that's artificially created there. You may see that in oligohydramnios as well. Here's some estimates of placental flow, and if you're really good, you can measure the umbilical vein in the abdomen and get some measurements and make some estimates of placental flow. Some nice work has been done by Dr. Achari and others in doing this, and this may have some utility, although I don't see many perinatologists using it to assess IUGR at this point. And again, we talked about ductus venosus shunting. Well, let's talk about the ductal arch and the ability to measure the velocity in the ductus arteriosus. Well, as I pointed out before, this is kind of like a right-hand turn and then a U-turn, if you will. So we're going from the pulmonary valve to the main pulmonary artery to the proximal ductus and then to the descending aorta, and the velocity is changing all the way along that pathway. So as I mentioned before, making a measurement of flow in the pulmonary valve can really be tough. Here's kind of like what we should do here. This is from the paper where we had some ductal constrictions from indomethacin, but you can see that I have that even the author of this article, yours truly, got the angle wrong here. He wants to be over here, okay, tangential to the flow, if we can possibly do so. Now, sometimes it's impossible to do. Anybody listening ever take triplets or quadruplets on indomethacin and get their ductuses, you know that sometimes that's all you do during the fetal echo. But if you're quick, you can do it almost blindly by getting, especially up behind the baby like this, using your continuous wave Doppler, and there's no other velocity you're going to confuse it with. You don't have to image with color Doppler to get the correct ductal pulsatility index and exclude ductal constriction. Another example of this approach, and here's some color Doppler that initially looks like, gee, this is a pulmonary artery, and this looks like ductal constriction. Oh, well, that was just a part of systole. The baby moved a little bit, made it look narrow, and it's a completely normal ductus arteriosus. Now, you will see acceleration in this area because it's the highest velocity in the normal fetal circulation. Now, the ductal arch and the aortic arch have almost identical patterns, but the ductal arch always has a higher velocity. And so the point I'm making is, if you're looking for ductal constriction, don't worry about which one you're in. If you're not going, the high velocity is going to be in the ductus if you're looking for ductal constriction. And we mentioned before that the aortic arch or the aortic isthmus, especially the distal place isthmus, is a good place to sample for diastolic change in IUGR. Now, here's the transition from the pulmonary valve. You see it as a relatively low velocity. These are all the same scale. The main pulmonary artery, it steps up to this velocity, and in the proximal duct, it steps way up in the ductus arteriosus. And so the point I'm making here is just a slight change in the orientation or the angle, you're going to have a very big change in the velocity. In fact, in many of your ductal velocities, you'll see the high velocity, and inside of that, the smaller, lower velocity in the main pulmonary artery. If you're seeing valve clicks, on the other hand, when you're trying to do the ductus, that means you're in the wrong angle because you're picking up valve blood clicks, and that's way around the corner from where you want to be getting down toward the ductus, where the diastolic velocity should come up. And just one good example, since we're talking about ductal constriction, our first case of ductal constriction, when we were looking at this at Baylor College of Medicine, this patient took one dose of 200 milligrams of ibuprofen for Tietz's syndrome and had a nice, almost the indoor record of ductal constriction within a few hours after that one dose. Here's another example of ductal constriction from indomethacin with a high systolic and a high diastolic and a low pulsatility index that's 0.8. So as you know, the normal pulsatility index should be 2 to 3. So when you get down below 1, that's very severe constriction, almost always associated with tricuspid valve regurgitation. And here, I think it's quite nice to be able to quantitate the right ventricular pressure to confirm the presence of ductal constriction and the pressure increase that you're seeing in the right ventricle. And just some studies on ductal constriction. As you can see, those who had pulsatility indices with the ductal constriction, with severe constriction, also had tricuspid regurgitation. Another example of here, and you're wondering, well, where should I place my probe? You know, can I do it this way or can I do it this way? And my recommendation is don't depend on a two-dimensional color Doppler picture. Remember, there's a third dimension here that you have to take care of by moving the probe back and forth, listening to the velocity, and then maximizing it. Here's the way to get around the problem of a high cardiac output looking like ductal constriction. This is from Tulzer's nice paper on showing that the normal pulsatility index is 2 to 3 in the ductus. If you have a high cardiac output for a variety of reasons, and in our patients, some of the patients were having contractions and the cardiac output was elevated, you'll get a high pulsatility index. That's not ductal constriction. So you can't just use the systolic velocity. Ductal constriction should lower the pulsatility index, and when it's below 1 is where you'll see a lot of tricuspid regurg. Here's an example of a patient on terbutaline, for example. A 2 meter per second systolic jet, a high systolic jet, but no diastolic elevation, and a high pulsatility index. So again, using something like the pulsatility index is really just a mathematical tool to try to even things out over gestational age, rather than having to always go back to your gestational age curves for what the normal velocity is. And one more example of the same thing. Here's your normal ductal velocity. Here you see the main pulmonary artery velocity inside of it. Here you see a patient who has a high cardiac output on terbutaline, and that might look like ductal constriction, but the PI, in fact, is elevated, whereas this patient has a high velocity in systole, but also high in diastole, with a low pulsatility index consistent with ductal constriction. So these two states can be differentiated using that simple mathematical tool, systolic minus diastolic over the mean, the pulsatility index. So in summary, we'll try to use non-parametric measurements if possible, and those that are angle independent are handy. If we can optimize the angle using landmarks, that's helpful, but boy, it's hard on the right ventricular outflow tract and the pulmonary valve to get the right answer. We're going to use CW or large sample volumes, 8 or 10 millimeters in size, for our pressure gradient assessment, and then we're going to try to correct for anemia. Now, finally, someone may ask, well, why don't we just do angle correction on our Doppler measurement? You know, we can see that we're off on the angle, so we'll just correct it for 20 or 30 degrees and we'll get the right answer. No. In fact, I don't use any angle correction in fetal Doppler. I think it's a big mistake because you'll overestimate your flows or your velocities significantly. And I think it's just an invitation for trouble. So use anatomic landmarks to get that third angle right. Maximize the velocity using a CW or a large sample volume. Adjust your wall filter and look out for anybody who wants to angle correct because they're probably going to get the wrong answer. Thank you.
Thank you so much, Dr. Hurta. Beautiful presentation as usual. The floor is open to the discussion. We start with our panelists. Anyone has a question to Dr. Hurta? Okay, by the time they prepare, what do you mean adjust the filter? You want it up or down, Dr. Hurta?
I want the filter up. I want to see a space between the baseline and where the Doppler velocities start. Take the filter up when I'm looking for a high velocity like TR or ductal constriction. That will get rid of the clutter, if you will, or the noise.
Okay, so make sure that it's really clean. I just wanted to say, maybe you would agree, if there is increased velocity, high cardiac output, and versus the ductal constriction, now with anemia and high output states, you will have the velocity increased. And so probably everybody looks at the velocity, but you told me to look at the PI. Now the PI is good for ductal constriction. So if we compare the diastolic flow, it's easy to know this is high velocity with the high velocity numbers. And the other one has a low PI with a high diastolic flow. It's not really in the differential because it's different etiology. Do you agree to that?
Well, yes, but we like to use it as a communication tool with the perinatologist. I think they can, even a pediatric cardiologist can remember 2 to 3. And so, if we have something that's lower than 2, we can give them a sense of the severity of the constriction or give them some feedback. We think that's probably easier to communicate the degree of ductal constriction.
Since we're in ductal constriction, I know that you like the list of polyphenols.
Yes, of course. We give a polyphenol food sheet to all of our patients who have ductal dependent congenital heart disease at the time of diagnosis, even though by the 3rd trimester when ductal constriction can occur. And it was really the observation that occasional hypoplast would show up with bad RV function and TR with no good explanation. I think some of those are related to the mother's diet. So we try to ask them to lay off the green tea and the other polyphenol containing foods for that period of time.
You told me you advise every clinic to have a list of the polyphenols because the list is getting more and more. And you like to give them to the mothers in the 2nd and 3rd trimester before they leave the clinic.
Yeah, I think it doesn't matter if they take a little bit of any of those things, but I think it's a woman who's just binging, if you will, on green tea, for example, it's been shown very clearly that even normal fetuses will have ductal constriction with that.
Dr. Ernie and Robbie, do you have any comments? Dr. Shawi and Dr. Alborbiros, any comments?
Always excellent, like usual. So he's the big teacher. I remember Rima, the first time I was in Paris, at the meeting, not first in Paris, 1990 or 89. At the fetal cardiology meeting, I asked some of the attendees, the specialists, about the ductus arteriosus. He told me, go to Dr. Huta, he's the specialist there. So you are since the beginning the king of the ductus arteriosus.
Oh my goodness, that's
excellent, really.
That
very
and
nice.
250 will get me coffee at Starbucks. But Robbie, it's great to see you, and I'll be in Berlin in in next month, actually in November. So I'll reach out to you.
Ernie, do you want to add?
Have a coffee.
Jim, it shows that you are a great biomedical engineer.
Exactly.
And do you see when you do pulse Doppler in a constricted PDA and pulse Doppler in the MPA, do you see the cutoff of the descent of the flow like what you see in pulmonary hypertension?
Oh, no, no, in fact, you mean in ductal constriction?
Yes.
No, ductal constriction is it looks just like a postnatal coarct, just high diastolic, high systolic. You can watch the branch pulmonary arteries though. If you have severe ductal constriction, your branch pulmonary arteries will occasionally, right at the beginning, they'll develop absence of diastolic flow or even reverse diastolic flow for a few days. And then they'll kind of normalize after that with chronic constriction.
Yeah. Assuming that one is able to interrogate the smaller branch PAs.
Yeah, no, we do that routinely, and then in patients where we suspect pulmonary hypertension or there's an issue like this, this twin recipient we're looking at, or with somebody who has diaphragmatic hernia, we'll do an oxygen test at 30 weeks.
What about twin, Dr. Huta? You were talking about twin and ductal constriction. I didn't get that. Is there any?
Oh, well, if you have severe hypertension like the recipient twin, then you'll start to see a velocity in the ductus that looks like ductal constriction, but all that is stiffening of the walls of the ductus arteriosus. So if you have stiff walls, it's going to appear that there's a constriction waveform pattern, but in fact, there's no constriction. Now, on the other hand, if you've done a laser therapy and you're using indocin for tocolysis, then I think you have to see the difference, but the before and after difference. But some patients with high pressures and stiff walls will have a velocity waveform that can be confusing.
You've been always saying that, but this is proven now. But I remember you were saying about sympathetic supply and you know, the difference between the innervation and donor and recipient, something like that. Is this now proven? I remember you told me this many years
ago. Well, I think there's no question that the recipient has become severely hypertensive, sometimes early 16, 17, 18 weeks gestation. And that's the basis of the, it's due to the small twin, you know, perfusing the large twin with vasoconstricting substances plus the volume overload. So that, you know, that can lead to brain damage and all kinds of problems. And that baby's heart is going to be very thick, whereas the IUGR smaller baby doesn't have much heart thickening at all, but is very hypoxemic.
Thank you so much. I'll just, we go to the MCQ because I think that makes life interesting. Now we're testing all our great speakers and the audience. This is from Anita Mongredi. Thank you so much, Anita. One question, it says, if you look at the polls and our audience already answered, all of the following are indicative of evolving hypoplastic left heart, except you choose one answer: a right to left flow at the atrial septum, retrograde flow in the distal transverse aortic arch, hypoplastic dysplastic aortic valve, LV dilation, and mild dysfunction. So the majority answered D, LV dilation with mild dysfunction. Dr. Huta, what would you say?
No, it's a right to left flow at the atrial septum is not what you see in an evolving hypoplast. You see left to right flow.
Okay, that's wrong. So which one would you choose? I mean, the majority chose number D as a part of evolving hypoplast, which is, I'm not sure if this is correct.
Well, it can't be. I mean, only one, all of those are correct except A.
Okay. So LV dilation with mild dysfunction. So is this like
Sure. Yeah, critical AS, that's what it looks like. Right?
You mean they're evolving endocardial fibrinostosis? Is this what they're trying to hint? Okay.
I think so.
All right. Ernie, you had some questions as well. You prepared a few questions.
Did you haven't asked the participants?
It's okay. I think we're I mean, we're okay. This is a comment from Dr. Awad, Southend from Rush. It's not a question, but a comment. This is related to Bree's great talk about the PFO. The redundant restrictive PFO in the setting of normal heart is often missed. The scanner will assume that PFO is wide open, not realizing there is redundant septum primum. Any comments? So Dr. Awad is trying to explain the redundant and the value of redundant restrictive, and why is it important to try and look for that, because it's often missed. Dr. Huta, Ernie, and Dr. Rabi, and whoever from the panelists, do you have any comments on that?
I agree. You know, I'm actually one of those patients. The sonographer was paying so much attention to the VSD, no one was even noticing how floppy and redundant the septum was for the one that I presented. So I think that's what her point was. And I think, as I mentioned, you know, I think a lot of times we just don't pay attention as much to the foramen ovale. Maybe that's just me, but that's when everything else looks normal. I think it's kind of left aside, but I'm going to start doing more with it.
So your message is, one, if you see a ventricular discrepancy, go back and check the, especially right ventricular, go back and check the diameter and the ratios of the foramen ovale to the septum, or whatever you, or the Doppler. Is this the message here?
Right, but I think it's also important that that diameter that we think is the diameter can look normal. That's the point. The diameter can look normal, but the actual septum primum can be restricted, right? Maybe this is where 3D would be more helpful, because this structure is this 3D. We see it as this 2D thing, but we forget that it's this flap of tissue that might, it could be fenestrated with just very small holes, like that one that I showed. So,
well, power Doppler seems to have helped us a little bit, I think. Some of the power Doppler imaging, that gives you kind of a three-dimensional kind of feel for the fossa ovalis, and sometimes you'll spot a narrowing doing that.
Dr. Hutte, do you agree that restrictive without Doppler? I mean, would you say this is restrictive just by the way it looks or the ratios, or you always join this to Doppler values or Doppler flow pattern?
I don't think I can do that.
Yeah. Yeah. Bree, from Dr. Awad as well, how would you counsel the family regarding restrictive PFO versus coarctation? That's a serious question.
Right, exactly. I think if you see those findings of the septal tissue that you're concerned about, you say, I would say that depending on what the isthmus looks like, that most of the time these babies do fine. But of course, I would talk to them and say there's the possibility of a small arch, and all of those cases that we had, we, watched them closely after birth and did serial echoes and make sure that we're not missing something. And, I think families usually respond to that really well, and you're just, open with them and tell them the possibilities, and they appreciate that.
Thank you so much. We're getting late. I'd like to thank all of our attendees, and would like to thank the audience as well. And this is our 9th episode. We want to thank Dr. Silverman, who's been with us all the time, but he's on holidays nowadays. So we miss him so much, and hopefully next month we'll have him back. Thank you so much, and appreciate your presence. Thank you. Whoever is interested, thank you. Whoever is interested, you can find the whole episode on the YouTube on the Congenital Heart Academy / Fetal series. Thank you so much.
Thank you.